Good afternoon and evening, everyone. Thank you so much for joining the ASPN Virtual Think Tank Session 3 today. We are so excited you are here. We will give a few more attendees some additional time to log on. We will start promptly at 7:02 Eastern Time. So we will give about another minute for people to join us. Thank you for being here. The session will start momentarily. Good afternoon and evening, everyone. Thank you so much for joining the ASPN Virtual Think Tank. This is session 3, focusing on targeted drug delivery and SI fusion. The webinar will begin in just a moment to allow a few more people time to log on. Again, thank you for joining us. We will start in just a moment. Good evening, everyone, and welcome to the ASPN Virtual Think Tank. Thank you so much for joining us tonight for session 3, which is focused on both targeted drug delivery and SI fusion. I'd like to introduce our two moderators tonight, Dr. Dawood Syed and Dr. Timothy Deer. Gentlemen, take it away.
Thanks, everybody. Thanks, Michelle, and thanks for everyone for logging in again. We are now in day 3 of the think tank. We really had two, which I thought were fantastic sessions on spinal cord stimulation. Some of the sessions with really established companies in the space, as well as some of the emerging companies and their new technology. So I think it was a really great discussion led by really engaging faculty. Today, we're gonna pivot a bit and move away from spinal cord stimulation, and we have kind of a hybrid session today with talking about targeted drug delivery as well as minimally SI joint fusion. I'm gonna let Tim say a few words as we intro into the session.
Well, thanks, Dawood. And as we go into night 3, it's amazing. We have a lot of folks sign up for the recorded content. So we have over 400 people tonight signed up for that recorded content with the live viewership as well. So I think this message will go out to a lot of folks who really want to really stimulate the mind. The think tank is about really sharing ideas, coming up with new thought processes in different areas of interventional pain medicine to do a better job for our patients. That's the whole goal of this. Also, we're going to give the content to the sponsors of the sessions in this think tank because they can share that with their physicians that they partner with, and also with to educate others. And lastly, as we go through the CME content of the annual meeting in September, that'll be very important. Tonight is not CME. Tonight is a time to really discuss things with our friends and those who do research and development of products. So this will be more of a discussion with collaborating physicians and as well as what's the next things we can do to help our patients. So that's the spirit of the think tank. And again, thank you for joining us tonight. Dawood, back to you to go over the agenda.
Yeah, thanks, Tim. So our agenda today, we're going to start with a few brief words from the treasurer of ASPN, Dr. Jonathan Carlson. He's going to talk about the membership drive. Dr. Carlson?
Yes, thank you, and welcome everyone to the ASPN Think Tank webinar, day 3. It's exciting. I really liken this to the Shark Tank of the non-CME event, but we can really think and collaborate with industry and finding different ways to really advance the space. And we're excited about what we have on board. Thank you to Flowonics, CornerLoc, and Pain Tech. As a treasurer, part of my role is to help promote membership and a membership drive. I kind of want to just present to you all the things that ASPN is. And if people ask, well, why should I join ASPN? There's multiple pain societies. We feel that we're the premier society, not in a boastful way, but I think proof of concept. As of today, we have 4,134 members. 122 of those are fellows and residents. 83 are actually international. So we have Australia, of course, North America, South America, Asia, and Europe. We're hoping to get Africa involved as well. But that's exciting. And so I think in that context, we'd like to continue to grow the space. We really want to be the hub for all pain management, neurosurgery, neuroscience, neurology, PM&R, anesthesia-based pain to treat our pain patients and functional medicine aspects. So I encourage you to get your colleagues to join. What does ASPN do that's different? Well, I think we have one of the best, if not the best, annual meeting. Everyone talks about NANS being kind of a Super Bowl meeting of the year, but really that's nice, but it's neuromodulation. We really touch all the points in pain, and we want to talk about sustaining technologies, new technologies, things that are on the horizon. So we encourage you to be a member, encourage others to be members. Right now, we are the lowest priced membership in the country, I think in the world actually. So keep that in mind. I just want to encourage you to attend the annual meeting. If you're a member, the rates should be reasonable. Some of the, actually for the fellows and the residents, there's no charge. For obviously members, there's no charge. But September 18th to the 20th is that. We have a newsletter that comes out quarterly. We are working currently, Dr. Deere and Dr. Saeed have worked tirelessly trying to get us linked to a peer-reviewed journal. I can't say what we're doing right now, but we should have our own journal very shortly. And so it's exciting times. We got the webinars that are CME based, a lot of things to offer, and we're open to suggestions of ways to be better for you as a society, not just nationally, but internationally. So again, I encourage you to get your colleagues to sign up, and thank you for your time.
John, that was amazing, and your enthusiasm. I feel it, man. That was great, and it's that Hawaiian spirit. So thank you for your great work as treasurer, all the things you said, and you're really your inspiration to me. So greatly appreciated.
Aloha, brother. Thank you.
Aloha. All right, Dawood.
So now we're going to jump into our first panel. Our first panel is led by really some highly respected leaders in our field, Dr. Jason Pope, Dr. Pooja Chopra, Dr. Navdeep Jasal, and Dr. Gladstone McDowell. We're going to have just a kind of an open panel discussion with these experts around intrathecal therapy and kind of what the future holds. Tim, would you like to shoot these guys the first probing question?
Well, I think I would. And, our goals here with such a great group of folks is really to think about, kind of what can we do to move the field forward. And so I'm going to start with my first question to Jason, because Jason and I, we've worked on pump issues for a few years, Jason. And this question is kind of one I've never asked you before. You got COVID-19 now as an issue. It's a pandemic. We wrote a paper recently on what to do with emerging from COVID and other things. For those patients who have pumps, it's a special issue because you can't really telehealth a pump refill. And you really can't telehealth a postoperative wound care issue. How do you deal with the intrathecal drug delivery patients during COVID-19?
Well, Tim, that's a great question. And I think as we try to physically distance people to try to eliminate or reduce the spread of COVID, there are some patients that we take care of that require in-person office visits. And so you want to take every precaution that you can to make sure that you're keeping your staff safe and you're keeping your patients safe. I think documentation is really critical. I've reviewed a lot of clinic documentation from other providers regarding intrathecal therapy. And I think updating simple things like the concentration of the medicine and making sure that the refill date is totally appropriate and documented appropriately is critical, because you want to make sure that as patients need to be refilled, that's something that my hospital system has designated as being something that does not require COVID testing in order to be done. Similarly, pump replacements, so those pumps that are end of life that need to have continued therapy, those patients are ones that are in more of the emergency instead of the elective scenario, and so we've tried to usher those folks along. And then unlike, I'd say this, very similar to some of the other medical devices that we have, a lot of the things that we do cannot be done remotely, and titration is one of those things. So making sure that you have prepared your office to titrate the pump appropriately, taking every precaution to make sure that you protect yourself and your patients critical.
Oh, great answer. I think that you really summed up. I couldn't have summed up in any better way, Jason. Thank you for that. Darwin?
Yeah, my question is for Dr. Chopra. As a younger physician kind of coming on and establishing your practice, one thing that I hear from many fellows or new attendings is that we didn't get exposed to pumps during our training. So say, for instance, that is the case for a future physician or someone that's trying to bring pump into their practice. For you, what are kind of some really good resources, or what are some go-to sources of literature that you would direct those people to?
I think that's a great question. I've heard that, and I've participated in some of these conversations at various conferences in the past as well. And, you know, we're very fortunate in this era that we're in. And I think, you know, probably one of the only few pros that we have right now with the whole COVID situation is, you know, we're really utilizing technology, and we have so many resources. One is specifically for pumps is PAC guidelines. I've reviewed them numerous times throughout my fellowship, and I think, you know, knowing that fellowship is only 1 year and trying to get the most that we can during the short time span, really utilizing and doing your homework outside of maybe your experiences in fellowship, because I think many of my colleagues this past fellowship year can agree with me when we say that we definitely missed some clinical and procedural time, but I think a lot of us have really utilized our resources, whether it's research studies, going through journals, using a lot of other learning resources that are available.
Fantastic.
So Pooja, when I met you as a resident, I knew you'd be amazing, and you're proving me right. So it's a great answer, and I really appreciate all the things you're doing. Dr. Chopra is going to be a great leader in our field going forward. But we already have another great leader here because he's already been around for a year or two, Gladstone McDowell. Gladstone, she mentioned the PAC guidelines. You know, you actually, most people don't know this, but you led the CME approved PAC app that INS came out with to go through the PAC guidelines. But I have a question for you that relates to that, but it's really more about practice and safety. What drug, if you're a doctor like Dr. Chopra who just started doing implantable therapies, what drug would you start a new patient on in a pump usually? What type of drug would you use? And what types of doses and concentrations do you start out with a new pump patient?
So it depends upon what I'm treating. Thanks for the question, Tim and David and the panel. So, you know, I look at the pathology that I'm treating. If I'm treating somebody with non-malignant pain, my preference is to start with a non-opioid and figure out where the pain generator is, decide how I'm going to test that particular drug, whether I do a trial on them, or if it's a patient that has it's a palliative care issue or a cancer issue, we may not do a trial. But when I figure out where the pain generator is, then I want to place a catheter close to the source of the pain. So as you guys all know, I am a big Prialt fan. For better or worse, I've had the bumps, but also the benefits of it. I think that for me, I would start somebody with non-malignant pain on that, if their insurance allows it. I would titrate up and then decide if I need to add a second drug to that. If I have somebody with a purely nociceptive pain issue, like a little old lady with a compression fracture, you know, some of those people do quite well with just a little morphine, a little Dilaudid, again, trying to place a catheter close to where the particular pain generator is. So that's sort of how I think about it. For a cancer pain patient, I'm much more aggressive. I don't trial those patients generally. I put the pump in, and then I'll start them with a combination of an opioid and bupivacaine generally, particularly because it's usually a combination of nociceptive plus neuropathic pain. Again, making sure I know where the catheter tip is. And then I start titrating up to tolerance. With Prialt, you have to start low and then go slow. If you have side effects, I stop, I wait, I manage the side effects. You've got to have a lot of patience. Then I keep going up slowly. If I'm using a opioid, I start with a dilute concentration of the opioid because it gives me much more flexibility in terms of titrating. And you know, I see patients quite often. So I think pump therapy, you don't make a lot of money doing pumps, but you change people's lives. So I tend to see my patients much more frequently and then titrate them based upon a face-to-face interaction with them, COVID permitting.
No, great answer. And I think that's good guidance for our younger physicians. Everything you said, I totally concur with. Dawood, you have the next question?
Yeah, my question is for Dr. Gisal. So, you know, the last 2 days we dove into spinal cord stimulation, and there's been tremendous innovation in that space. new waveforms, new frequencies, new hardware. It seems that, you know, from the outside looking in, if you don't do pumps, have been kind of stagnant. But as you kind of delve into some of the new advances, I think there is some innovation in pumps. Why have you decided to kind of use the pump you do and the dosing regimens you do? What's kind of new and innovating, exciting there, and some of the technological advances in pumps?
Sure. So I'd love to answer that question. When I first trained on pump therapy, I primarily used one pump at a cancer institution. Really didn't have any sort of understanding of another pump that was out there. Definitely, when you start exploring pumps, you should explore the mechanics of the pump itself. How is the medication being delivered? Is it, you know, piston with a gate delivery, or is it going to be something that is a gear mechanism? Those little subtle details do make a big difference in the way that the patient is administered the medication and the way they have their analgesic effect from the medication that's delivered. So primarily in my practice, for a lot of the non-cancer pain patients, my choice of pump has been Fluonic, specifically the Prometra 2. Specifically, I've been toying with or playing with periodic dosing as well in my practice. I've really seen a change or a difference in the way I can administer the medication, specifically at low doses. And I know, you know, I was speaking to Dr.
Let me ask you, what could you just explain what periodic, before you, not to interrupt you, but I think it's important. Sure. Because I think many of the people who will listen to this live or in the recording won't know what periodic dosing is. Could you explain
Sure.
that?
Absolutely. So specifically, we all know or hear about continuous standard dosing, or continuous dosing is the way that medication is slowly delivered at a continuous dose throughout a 24-hour period or whatever period that you want to administer that dosing. With periodic dosing, you can actually administer bolus dosing, and you can actually personalize the therapy to the patient. And so if a patient has, you know, purely neuropathic pain and their pain is worse at night, where we, you know, see with a lot of our, you know, peripheral or diabetic neuropathy patients in the feet, a lot of times you can deliver a bolus dosing at night, or you can target the therapy at particular intervals at whatever interval that you want to do. I choose to deliver the doses at a very small, a small dose delivery, sometimes even 1 microgram or very small interval dosings of medication, so I can actually lower the amount of medication given to the patient and allow for flow to take over for the patient. Of course, Dr. McDowell mentioned catheter location is key, but I also think flow dynamics is key, and that's where periodic dosing really comes in handy for your patient.
No, great answer. I want to ask you all a very, what I would call a rapid fire question, because we want to get through make sure. I'm going to start with Jason, then Navdeep, then Pooja, then Gladstone. So Gladstone, you have the hardest job. You have to do the last person. Tell me, if I'm a person that does mostly spinal cord stimulation or mostly, you know, vertebroplasty or kyphoplasty or spacers, now I say, okay, maybe I should be offering pumps to my patients because maybe I'm missing helping people I could help. I want you each to tell me in maybe 30 seconds to a minute at most, tell me a great candidate that I may have in my practice today who could benefit from pump therapies that would really help them. Jason, we'll start with you.
So a lot of the other therapies, just like intrathecal therapy, there is a failure rate. So for spinal cord stimulation, it's around 30%. For vertebral body compression, there is a failure rate also. And we have the New England Journal of Medicine article that we all don't agree with, but there is data out there to say that conservative medical management can be helpful for some folks. But I've also seen failure of that therapy. I've seen failure of spinal cord stimulation. I've seen failure of peripheral nerve stimulation. Intrathecal therapy is viable because it does work. And we're delivering a medication into the intrathecal space. Obviously, everything that Dawood, Navdeep, and Pooja have described, I think, are really important in terms of placement of catheter and patient selection. I think a big innovation that we need to have in the space is better data on the non-cancer pain population, and a lot of us are working on that right now. But you know, largely, in my opinion, if you do not offer intrathecal therapy to your community, then you're doing your community a disservice, because there is good data, observational data, retrospective data to say that it does work, and it is another option as an alternative to systemic high-dose opiate therapy. So I do think pump therapy is something that we should all consider.
Navdeep, same question.
I think a lot, well, I'll answer it from a Florida perspective. From a regional perspective, I think the patients, I would love that spinal cord stimulation or DRG therapy would work for everyone long term, but there will be a failure rate at some point for some types of patients. In my practice, I've seen some failures, especially for patients with spinal stenosis and multi-level spinal stenosis. Of course, if you can't treat the problem with the decompression, both indirect or direct, and they're not candidates for surgical intervention, LAMI with or without fusion, they are excellent intrathecal therapy patients. It is a life-changing therapy for little old grandma or grandpa, and I think I've utilized it in my practice and changed a lot of lives.
So we have failed other therapies. We have spinal stenosis. Pooja?
So I agree with what Dr. Pope and Dr. Dressel said so far. You know, like any other procedure, it's extremely important to recognize specific indications and whether that patient that you're considering, whatever procedure you are, that they would benefit, and it is indicated. So with intrathecal therapy, it's extremely important to recognize, first of all, the diagnosis and the specific pain pattern, whether the pain is local versus diffuse, whether it's cancer versus non-cancer pain, whether it's nociceptive versus neuropathic pain. I think all of those are important concepts. And in addition to what Dr. Dressel was saying in regards to the specific pain diagnoses, other diagnoses that or scenarios where intrathecal therapy would be beneficial is for patients. Sometimes it's an alternative to spinal cord stimulation for axial neck or low back pain, failed back syndrome, or even you can use it synergistically with spinal cord stimulation. There's sometimes patients that are experiencing inadequate pain relief despite spinal cord stimulation, and I've seen certain scenarios with patients having synergistic and appropriate and adequate pain relief with a combination of both.
No, I think that's really interesting when you have, and I'm going to build on your question. Actually, you and I have been working together a long time. You kind of put about where my mind was. Gladstone, I'm going to ask you one little variant of that, and then back to Dawood for the last questions of the session. So let's say you get a patient from somewhere else in Ohio, and they've had a stimulator in. They failed back surgery, they failed medication, they've been doing poorly. Stimulator goes in, they have a paddle lead, and they're getting 50% pain reduction in their legs, but their back is still unbearably painful because of mechanical pain. Is it appropriate to put an intrathecal drug delivery system in someone who has a partial response to another therapy, whether it be spinal cord stimulation or another back surgery or kyphoplasty? Is it appropriate to use combination therapy?
Absolutely, Tim. So I talk to patients all the time about the concept of a stump, a stimulator and a pump, because unfortunately there is a small subset of patients, unfortunately not as small as I would like to see it, where stimulation was chosen as the primary therapy for pain that was primarily axial weight bearing, and therefore was not completely successful for them. So I've taken patients like that who have partial relief. I've placed a catheter in the appropriate area and added intrathecal therapy with a local anesthetic or a combination of that with a opioid, and use that to improve the relief that they're getting from their paddle or their round leads. And I talk to people and make this joke about it being a stump. I didn't get that. I stole that from Alan Burton, by the way. But also, you know, there are these people where they have failed neck surgery, either anterior or posterior. And posterior, they may not be a candidate for a stimulator. But patients like that, particularly certain insurance companies who don't deem failed neck surgery to be appropriate for stimulation, I'll place a catheter in the cervical spine and treat those patients very, very well with some form of intrathecal therapy. And then one of my favorite things to do is for the patients who have had partial relief from some type, either vertebroplasty or kyphoplasty, and it just has not persisted. Those people do very, very well with intrathecal therapy with an opioid with a local anesthetic, or maybe sometimes only local anesthetic alone.
So I love you and Ellen Burton, but that naming's terrible. We have to work on the marketing of you guys. Back to you, Dawood.
Yeah, I kind of liked it. So I want to give everyone a chance to answer this question too as we kind of close this session. So, this is more of a kind of a forecasting thing since we're in the think tank. Intrathecal therapy, what do you guys see as its future? On one hand, we have the opioid epidemic, and you would think that potentially intrathecal pumps would be something that seemed like a viable alternative to systemic opioids. But then on the other hand, you have like this, innovation explosion with a lot of the other therapies that we can offer our patients. What do all of you, and we'll start with Jason, see for the future of intrathecal therapy? Is it going to decrease? Is it going to be flat, or is it going to grow? And then tell me why you think what you think.
Well, that's a compound question. So I will say that I think, and I'm hopeful that intrathecal therapy, the presence of it in our space will increase for a lot of different reasons. I think as we get a growing body of evidence treating the non-cancer pain population in a randomized prospective comparative way, I think that's going to offer support for not only insurance carriers, but also patients and physicians to reach for this therapy confidently. I think the innovation in the space, Dr. Deere gave a wonderful lecture at NAN some time ago surrounding some of the innovations in medications that can be delivered intrathecally, and I know there's a lot of work in that department. Looking back at the tenure of my time employing intrathecal therapy, there hasn't been much change with the medications that we deliver, but how we deliver them and where we deliver them. I think the pharmacodynamics and kinetics in the intrathecal space, as we get more information and we're more savvy with how that works, I think will improve outcomes by placing catheters and using drug infusion strategies that support patients individually. We talk about spinal cord stimulation and minimally invasive spine work and peripheral nerve stimulation. Think of this as a kind of developing the phenotype for the patient and treating one patient one way and another patient the other way. I think we'll have that granularity with intrathecal therapy, and I think it has a bright future. We did a survey, Tim did, amongst some of us on the webinar today, looking at where we are with intrathecal therapy as a space, which is a new iteration of the PAC guidance, and I think the future is bright. There is some work that needs to be done. I think we need to educate our educators that intrathecal therapy is something that should be prominently focused on in fellowship, but I do think the future is bright.
Great. Dr. Jossel?
So that was such a well-rounded answer by Dr. Pope. So I'll try to add to that. I remember hearing a statistic when I was coming out of fellowship, and I think the statistic was something that 3% of interventional pain physicians actually embrace pump therapy. And I don't know if that's right, but that's a terrible number. So in terms of the answer of is the future bright for intrathecal therapy, absolutely it is. And I think one aspect of it is because there is such innovation in interventional pain going on right now. And whether we talk about treatments of minimally invasive therapies, I know and I feel, my gut feeling is that there's going to be a lot coming in the horizon with choice medications to use in the intrathecal pump. Alluding to that same talk at NANS, I remember it was at NANS in 2018 that Dr. Deere gave, and there was a whole slew of non-opioid based medications that could be utilized in intrathecal pump. So I'm very hopeful to see others besides Inconatide that's currently out there and FDA approved. The other things that we know, of course, it's safe and efficacious, but the other thing that I'm very hopeful of seeing is that it's going to be extremely cost effective, and we know it is, but I think by certain studies, prospective, multi-center randomized trials, such as the PROSPER study led by Dr. Pope here on the panel, I think that's also going to prove not only is it safe and efficacious, but also cost effective. So I think the future is extremely bright, and I'm truly excited that younger people are embracing pump therapy, just like Dr. Chopra here on the panel.
Yeah, great answer, Dr. Gisal, and I think that's a great plug for the PROSPER study that Jason's leading. I think that's really going to be really important data that's, kind of, I'm almost ashamed of our specialty that we haven't produced it yet at this point, but great job for all the people involved in that study. Dr. Chopra.
I don't know how much more I can add after these two, but I'll give it a shot. I agree. I think that it definitely is a growing therapy, and there's a lot of growth and potential with intrathecal therapy, especially with all the technological advances in our field, and even as we've seen within specifically the field, like this aspect of intrathecal therapy and pumps, but also novel programming settings such as periodic flow that we've experienced and we've seen with patients how much how much adequate analgesia they have received. And I think that there's just, for all of these reasons, we have a lot of treatment modalities and more options for our patients to provide better analgesia.
Great answer. And Gladstone, I think for you, you can decide to either answer that question or give us some closing thoughts to end the panel.
So my thoughts are, I agree with everything that everybody said. I think the future is bright because I love the flow dynamic info that we have now, the different drugs coming out. I'd like to see smaller sizes. I think that not everybody is going to respond to some of the fabulous new things that we're going to do. So pumps will always be there. I think an important thing is that we need to change the culture that all of us perhaps grew up in, where the pump was the last thing that you did. We now know that we probably should think of intrathecal therapy if somebody's not a candidate for some of the more minimally invasive things earlier before starting them on high dose or prolonged opioids, particularly in a younger patient. And I think the future is bright. I think it's up to us to educate the future, as we have two of the future here, along with us older guys, so that we can change the culture so pumps are not thought of as the last thing, because I think there's a lot of innovation coming with them. So thank you all for having me, and I'll turn it back over to Tim and David.
Well, that was a great word of wisdom, Gladstone. So I think that's a great way to end the session with really 4 of my favorite people. So I would love to have all 4 of you on tonight. You really added great value to the discussion, and wish you all the best of the weekend and the rest of this week. So thank you so much,
everyone.
Yes, thank you.
Thank you.
So Dawood, we'll move on to the next 2 sessions of the night. And again, we're going to be very efficient tonight, but we have 2 sessions that will be very important. And that really is a movement towards minimally invasive procedures to lower risk and improve outcomes. And that's the goals of minimally invasive procedures. And also we have a secondary goal of reducing costs and improving quality of life. So with that, I'll have you introduce the next session.
Yeah, absolutely. I'm really excited to launch the second half of the think tank, in which we're going to kind of delve into what I think is kind of really the hottest kind of therapy in the field right now. It's kind of all the rage when you talk about minimally invasive SI fusion. So we're going to have Dr. Falowski and Dr. Patterson lead off this session to talk about the CornerLoc and stabilization and bone healing and SI joint arthrodesis. Gentlemen, good to see you.
Good to see you, Devin. How are you?
Well, Stephen, Dennis, good to see you.
Good.
Thanks for joining us.
Well, so I'm going to start tonight's presentation for Stephen and I'm going to talk about a little bit of the background on SI joint dysfunction and patient characteristics, or what you're exactly looking for, and who's an excellent candidate for a posterior SI joint stabilization procedure. And then from there, we'll talk about the advantages of what we think are for the posterior stabilization procedure versus the lateral known procedure that's been out there for a little bit longer. And then from there, I'm going to turn it over to Steve to talk about CornerLoc and how we think that it is an excellent player in the market for a treatment option for your patients as you see and treat them. So I'm Dr. Dennis Patterson. I'm a physical medicine and rehabilitation doctor in Reno, Nevada. Did my pain fellowship at Emory, and from there, I decided to come to Reno to offer my services, and been here now for about almost 15 years, seeing and treating patients with chronic pain. And my disclosures are at the bottom. Consultant for several companies, did a lot of speaking and national training, And I just want to thank ASPN and CornerLoc for allowing me to be a part of tonight's webinar here at the Aspen Think Tank. It's just too bad we could not have done it earlier this year in the Bahamas. Next slide. So let's talk about the SI joint in general and give a brief overview of it. So patients who present to your clinic, it is believed that up to 20% of these patients who suffer from lower back pain is due to SI joint dysfunction. And when you look at SI joint issues, you can break them down into two categories. You've got more degenerative conditions, or you've got more of a disruption or a traumatic type situation that can cause this joint to be painful. So let's talk about the different types of degenerative conditions. Well, one can be a prior lumbar fusion. As we all know with our patients that we see and treat who've had prior back surgery, you can get adjacent segmental disease. So patients that are fused down to L5-S1, we can see that the SI joints are the joint below that, so they can become hypermobile and cause a patient pain. Second thing is you can get primary arthritis of the joint. So patients who unfortunately got bad genetics from mom and dad who suffer from arthritis, this is a synovial joint, so it can affect that joint as well. You may develop have an underlying arthritic condition like rheumatoid arthritis, SLE. Those different conditions can go after the SI joint, especially in patients who have a positive HLA-B27. And then how about patients who have had an iliac crest harvest procedure to use that for other fusions of their spine? They can develop arthritis of the joint as well. Now, disruptive conditions of the SI joint can be like a fall. So if you have a direct fall onto the buttock area, that can shear the joint and cause pain. Same thing with patients who are involved in motor vehicle accidents. If you think about your feet outstretched and rear-ending somebody or getting rear-ended, the mechanical forces through the leg will go through the SI joint and cause shearing of the joint and can cause lower back pain in patients. Then you've got patients or females who are of pregnancy ages who have delivered kids. Well, the loosening of the ligaments for that process may not tighten up after they've delivered the child, and since they've got a little hypermobility of the joint, that may cause them some pain moving forward. And that's the same with these women after delivering, that they may have postpartum pelvic girdle pain as a result. Next slide. And this kind of goes back to patients with fusions. I just want to point this out. I think, we're all aware of the adjacent segmental disease. And I think initially when I was looking at doing SI joint dysfunctions and talking to my advanced practitioners, there was concern that, okay, if we fuse this joint or stabilize it, are we going to cause adjacent segmental disease in return, the hip or the L5-S1? So let's look at the first condition. Patients who have a lumbar fusion. So patients who are fused at L5-S1, there is a 52% increase of stress across the SI joint. So that's pretty big. And that's why patients who have a prior SI joint, a prior lumbar fusion, develop SI joint dysfunction up to 40% of the time. Now, if you extend that fusion from L4 to S1, you even see the forces increase even more across the SI joint. We see that 168% increase in stress across the joints in that condition. But let's look at the converse on the right side of our picture here. If you fuse the SI joint, how much stress are you putting across the lumbar disc? And what we see is it's only a 2 to 4% increase, very low compared to what we see when you fuse those joints and what it does to the SI joint. What does that do to the hip? Well, it only increases the stress across the hip about 5%. So I think we can feel more confident that stabilizing the SI joint, we're not leaving our patients prone to adjacent segmental disease, just like we see with lumbar fusions. We're really causing a lot of stress on the SI joints in those patients. We know that the joint naturally has about 2 degrees planes of motion in all planes. And we know that hypermobility of this joint results in instability and pain, but there's really not a definitive number. So if we, how much more motion can this joint have before it develops pain for patients? And as I was saying, patients who have a lumbar fusion, you see an increase in back pain, or 40% of these patients will develop SI joint dysfunction as a result of that spinal fusion from these forces that we see on our diagram on the right. Next slide. And so patients who are going to complain to your clinic, not only are they going to complain of lower back pain, but they're going to complain of different types of symptoms as well. So one, we're looking for pain below L5. We're looking for pain in the pelvic buttock area. It may even describe some anterior SI joint pain that they'll describe as being in the hip and groin. These patients may tell you that they have difficulty sleeping at night, that when they roll over in bed, it mimics their pain. And then since the SI joint is what links our lower back to our lower extremities, the patients may describe some leg instability as a result of the dysfunction. And they'll tell you that they'll have a hard time sitting on the painful side. And then they may even describe some radicular type symptoms, numbness, tingling, and weakness of the side of their SI joint dysfunction. So some people view the SI joint as being a mimicker of a lumbar radiculopathy. So you have to really do a good, thorough neurological examination to rule out radiculopathy with some of the patient complaints. Next slide. So conservative care of the SI joint. I think we all, try modalities, medications, maybe even bracing, an SI joint brace. What we find is those all make the patients feel good while they're using them, but they don't provide a long-term solution. So the next thing we look at is trying therapy. So physical therapy, maybe even chiropractic care or osteopathic manipulation of the joint to see if we can align it, tighten the muscles around it, and stabilize the joint by using the patient's own musculature. That may help out. Some patients end up on chronic opioids as a result of the pain. Interventional pain physicians, we've been doing SI joint injections for a very long time. And over the last 10 to 15 years, a lot of us have gotten into radiofrequency ablation with several different techniques to treat the pain. What we find is that, with steroid injections, sometimes patients are steroid non-responders, or it only helps for a short period of time. And with radiofrequency ablations, we can access the lateral branches or the posterior part of the joint to deinnervate the joint, but we can't access the anterior fibers or nerve endings. So we can't, there's no technique known to deinnervate those to give the patient relief. So they may only get a partial response to doing radiofrequency ablations. And if we look at our orthopedic colleagues, so we got Vanna Kloka, they did a study in 2017, and what they looked at, if you look at the graph at the right, is we see that patients who get conventional medical management or conservative care versus an SI joint denervation versus a stabilization procedure, we see that the conservative management and the SI joint denervation don't do well long-term over years, where a patient who gets in a stabilization procedure will do well long-term. And when you look at conventional medical management versus an RF procedure, you see the RF will help the patient for a short period of time, but then the pain will return back to its baseline and be no different than conventional medical management. Next slide. And I think in the opioid epidemic era, we're trying to avoid putting patients on chronic opioids. And the same study from our orthopedic colleagues showed that patients who got a stabilization procedure years out, their opioids are greatly reduced, or only a very small percentage, 7%, are still on chronic opioids after having that type of procedure. But when we look at the conventional medical management and RF denervation patients, we see that their opioid usage is, greater than 80% of these patients are still at opiates at a 6-year follow-up period. So from that standpoint, it looks like a stabilization procedure is helpful in reducing or eliminating opioids, while conventional medical management and a radiofrequency denervation are not. Next slide. So the patients that we're looking at to see who are good candidates for a radiofrequency ablation, we're looking for several things. One, we want them to have chronic pain, right? We're looking for them to have at least 6 months of pain that has not improved with conservative care. We want the pain, to be non-radiating or non-radicular in nature, so they want it to be more focal or localized over the SI joint. We're looking for a positive SI joint examination, and typically what we're looking for is that 3 out of 5 examination signs are positive, and that is Gainsland's, compression, distraction, a thigh thrust, and a Faber's. So 3 out of 5 is usually an indication that the SI joint is the cause of the patient's pain. What you'll recognize is that Fortin sign is nice to document, but it's not part of the 3 out of 5 examination signs. You want to make sure the patient doesn't have a generalized disorder that can account for their pain, like fibromyalgia or a conversion disorder. Then you want to have 2 diagnostic SI joint injections that provide the patient with at least greater than 80% pain relief while the local anesthetic is in the joint. That's very important. And then most insurances are looking to see that you have imaging studies that don't show any other pathology that can account for the patient's pain. Next slide. And if you look at the evolution of the SI joint fusions, you'll see that the lateral approach was a lot of hardware or metal. And next slide, what we see is that with this technique is that these systems put you at risk for vascular or neurological injuries, while the posterior approach eliminates any major vessels, and the hardware is not, or the grafts that we're placing aren't directed towards the neural foramen. We also see that with the lateral approach, you're bridging the joint, but you're not actually putting instrumentation through the joint or along the joint to actually fuse it. And then the hardware used is you've got a metal on bone interface, which can cross stress shielding, which then can lead to demineralization of the bone and ultimately a pseudoarthrosis or a non-fusion of the joint. And then last but not least, typically it's recommended with a lateral approach that the patients have to be non-weight bearing 4 to 6 weeks following the procedure, while the posterior stabilization procedures allow the patients to be immediately weight bearing after the procedure's done. Next slide. And with that, I'd like to turn it over to my colleague, Dr. Falowski, to talk about CornerLoc specifically and how it can benefit your patients. Thank you for your time.
Hey, well, thank you, Dr. Patterson. I think you did a phenomenal job of actually describing the pathology and the pathophysiology behind SI joint dysfunction and sacroiliitis. And I think it's important to realize that at this time, we're starting to identify these patients a lot more than we previously did. And I think part of that is because we have access to these therapies. You talked about somewhat of the evolution of the difference between lateral and posterior approaches. We know that, with SI joint fusion, it all started with lateral approaches that were performed by surgeons. And essentially, surgeons did these approaches transgluteal, which came with significant risk for hematoma or potential nerve injury. But it was thought at that time that, you would transfixing or going across the joint with either dowels or titanium screws would be the most ideal. And what's interesting is they had the 2 randomized control trials demonstrating its efficacy. But like you said, there's limitations, there's risk that's involved with that. And that led to the posterior and the posterior oblique approaches, which eliminated going transgluteal or through the muscle, eliminated that risk of hematoma or nerve injury, and gave you direct access to the joint for a lot quicker recovery and not having to be non-weight bearing. So that's the progression we have. But now by being able to offer the posterior approach and doing it with an implantation of grafts, we've now been able to give access to the interventional pain community to do this. And I think what that has done is it's opened up a large amount of doors for patients with this pathology. We know that this is a large amount of pathology with patients who present with low back pain, who present with posterior lower extremity radicular symptoms, and was highly underdiagnosed before because we had surgeons who either didn't embrace the therapies or interventional pain physicians who didn't have somewhere to send these patients for a more definitive approach to taking care of it. As we know, there are the minimally invasive and conservative measures such as NSAIDs, physical therapy, diagnostic and therapeutic injections, and then as well as radiofrequency. But as we know, none of these are definitive treatments. And as you showed very nicely, Dennis, on the graph a couple slides back, that these patients do significantly better with an SI joint fixation than they do with these other procedures because it's definitive and it has an endpoint to it. So what I'd like to do, though, is try to tie that all together. So now that we have an understanding of the pathology, the pathophysiology, and then also the evolution of how we came to be with these posterior approaches, I'd like to actually talk about what's considered ideal and why are these approaches working. It's important to realize now at this time we're basing a lot of our data on multi-center randomized controlled trials from lateral approaches. There are some case series and retrospective series looking at the posterior oblique approach. But at present time, right now, we do not have a significant amount of data for the direct posterior approach with graft implantation. Now, two of the major companies in the market, CornerLoc and CaneTech, are working on randomized controlled trials, and both are actually working on biomechanical studies, which I think is fantastic because this is what we need to push the space forward. Next slide, please. So just a little background before I move on myself. I'm a functional neurosurgeon. I was dual trained in complex spine as well as neuromodulation procedures as a functional neurosurgeon. I actually have embraced SI fusion for over 10 years, and I started off with the lateral approach and was very unhappy with the morbidity that came with that approach, and I quickly progressed to a posterior oblique approach, which is very similar to the posterior approach in that you're very close to the joint, except a little bit off lateral or oblique to it. However, with the posterior oblique approach, I was still placing titanium screws across the joint. But as most people know me, I am sort of that surgeon who bridges the gap between interventional pain and the surgeon community. And so it was very easy for me wanting to embrace these percutaneous posterior approaches to try to bridge that gap with the surgeons as well. Next slide, please. So this is just an example of some of the unique features with the CornerLoc system. It's a posterior approach, which is what we're actually moving towards now in fixating the SI joint. The nice thing about the posterior approaches, as we talked about, was the reduced morbidity from less blood loss, not being transgluteal, being full weight bearing. We've significantly reduced the time element for placing these grafts when compared to lateral or posterior oblique approaches. And the patients actually have very good outcomes with fast recoveries. Now, hopefully we're going to see that obviously play out in the randomized control trials that we're running with both companies. Now, specific to the CornerLoc graft, it is a 2-graft implant that's placed in a very specific manner in which the joint is actually prepared for the graft. This is something that a lot of surgeons look for when we place pedicle screw fixation, which is no surprise with the CornerLoc system being designed by an orthopedic spine surgeon that they felt that the joint had to be prepared. So that required rasping, it required tapping, it requires also using the drill to get decorticated bone or to place these grafts. Now, what's also specific about the 2-graft implant is that they converge on each other. Now, this is the idea of 2 important factors that we need for an SI joint fixation. One is, it's the idea that you need immediate stabilization. The second is the fusion that occurs. Now, fusion occurs 12 to 18 months following the implant of these grafts. It's also the same thing that happens when you put titanium in. However, the one thing we always know happens when you transfix the joint or place titanium screws is that you do have an element of immediate fixation. So therefore, the patient can start having immediate relief from the procedure and not have to wait to 12 to 18 months for the fusion. It's important when Dennis talked about the idea of when we fuse L5S1, we fuse L4 to S1. The pedicle screw fixation or placement of hardware in the lumbar spine actually maintains 80% of the strength of the normal power in your spine. So theoretically, even if you don't fuse, having pedicle screws in still gives you 80% of the strength of your spine. If you do fuse and actually get an arthrodesis across the joint space, that obviously can reach 100% or even greater than what you would have in a normal spine. So we are looking for the same thing in the SI joint. You want to have immediate fixation as well as the development of fusion over time. So also one of the unique features is that a DBM, a demineralized bone matrix sponge, is also placed, which promotes the graft to form a bony formation and create fusion over time. This is what is commonly used in the spine, like such as allograft or autograft. It's materials that we use to promote bony fusion. Next slide, please. And what we see here is this is a very interesting slide because it can get very in-depth about biomechanics and the environment that's required for these two elements, whether it's immediate fixation or bony fusion. But I do want to just kind of simplify this. The next two slides are going to really dive into a couple studies put together. But what it really comes down to is when you're looking at creating a bony fusion is when there's a compression force, one bone against another bone. That will create fusion because it creates tension on the bone. If there's one bone sliding on another bone, that creates a shear force. Ultimately, that can lead to the failure of grafts. This is why when we place interbody grafts in the spine, in disc space, we clear the disc space, we place an interbody graft, almost universally these grafts will fuse. It's because it's the compressive force of the disc space in the anterior portion of, or column in your spinal cord. However, we can have pseudoarthrosis or failure in fusions for pedicle screws because now they're oriented vertically without necessarily having a compression force on them. This creates a shear force so that the graft slides with the bone. That shear force will lead to the failure of a fusion. It will also lead to the failure of an immediate fixation. Next slide. So what you can see here is there's unique features that a graft can have that address both these elements. One is creating a diamond shape. This now wedges into the joint and creates more of a compression force than a shear force because it can't get past the corners of the graft. So this addresses both in the sense that you no longer have that shearing or sliding of the graft on the joint, as well as now having the compression, which leads to a bony fusion over time. Next slide. Now, I'm going to move on to the final few slides here. We talked about how both companies are now working on biomechanical studies. I think this is really important because to date, the only studies we have on the biomechanics of fixating the SI joint involved a 3-screw or 3-dowel transfixation across the joint from a lateral approach. And what we had from some of that data was that we knew that a 3-point fixation was better than a 2-point fixation. However, these were all done with lateral approaches. They did not include the posterior oblique or the posterior approach. But the truth of the matter is how much do you need? So we maybe know that 3 grafts is better than 2 grafts, can be better than 1 graft, especially if it's transfixating. But what about if it is in the joint? Now, if 3 is better than 2, can be better than 1. The question is what is enough? Is 2 enough compared to 3? Do you really need to place the 3rd? And the same thing can be said about placing 1 graft, and do you necessarily need a 2nd graft? So next slide. So CornerLoc has been working on a biomechanical study now for quite some time. This is done on a porcine model, so a pig model of the SI joint, in which they're taken from the pig, and these are considered normal joints. T-scores are tested. And in this study, 8 joints were tested, or 8 models were tested, in which 1 joint on one side was tested with the graft implanted, and then the contralateral joint was tested as intact or not being affected with surgery, so just considered a normal joint. There's 2 forces that were put on it after the joint was had the graft placed in it. One is a compressive force, as you can see here with the picture, which is from top to bottom to push down, which, as we know, that compressive forces, if your body can handle them, are great for inducing fusion. The other is rotation. Now, this is important to realize when you think about the biomechanics of the SI joint. The SI joint does just not move in one plane. It is a rotational joint. It moves in flexion, extension, rotation, as well as compression, meaning up to down. We know for the most part, it's meant to be an immobile joint. That's why when we do these SI joint fixations, we're basically trying to promote immobility in the joint or restore it back to the state where it does not move much. And what else, the other part that we did with this study is that we followed it in cycles or deformation, which means we didn't just test it in one element where we placed them in flexion and extension once, did compression once, did rotation once. We tested over multiple cycles. In fact, we did over 200 cycles to see would the graft hold up and would it hold up to the same point as an intact joint will hold up. So as we know, the more wear and tear we put on any joint in the body, it will deform or eventually degrade to a certain amount of movement, which the same thing happens in an intact SI joint. Next slide. So what we can see here with the results of the study, it showed that under compression, the implanted joint, the red line you see there, deflected less. So what that tells you is that by putting in the graft, there was an immediate fixation to stop movement in the joint. And over the 200 cycles, this held true completely. And it did not lose that immediate fixation on compression that you had. And it was much less movement than an intact joint on the contralateral side. They also looked at rotation. Now this is important because this has to do with the degradation or deformation of joints in anywhere in the body. The more cycles you put on it, the more movement you will get in those joints. Same thing happens in your knees or your hips, but also in your SI joint. So what you can see here is that the implant actually degrades or deforms at a pretty much very close rate as to that of the intact joint. And eventually they actually settle in and become very close together. What this also shows you is that with the graft implanted, not only are you getting that immediate fixation and you get less rotation or less movement, but eventually as you degrade, they eventually come together, meaning that over time, the graft will not create an abnormal joint or abnormal movements in rotation in the SI joint. Next slide. So what's the importance of decortication? I think this is some of the unique features. We talked about rasping and tapping and drilling of the space. But this is also important because this leads to a lot of growth factors. Putting in the demineralized bone matrix or allograft to promote bone effusion will work better when there's a local inflammatory response where you can actually have demineralized bone there or decorticated bone promoting fusion and growth at that site. Next slide. So this is just an example of what the CornerLoc device looks like and how it's implanted. And what you can see is these grafts converge. The ideal situation would be them converging at 45 degrees. One is placed at the top portion of the joint, the other is placed at the inferior portion of the joint. This would make sense if you want to place two grafts for a two graft fixation to have them converge like this, and with that diamond shape eventually leading to an immediate fixation, and then we talked about the potential for increased fusion over time. Next slide. So I think at this point, we were going to bring it open to questions, see if anyone had questions, and also Tim and Dawood chime in as well.
Yeah, I think we have a few questions for both of you. Dawood, you want to ask Dennis the first question?
Yeah, excellent presentation, gentlemen, as always. You guys are always so polished and do a great job, no matter what you're presenting. Dennis, actually that slide you posted on the study of looking at conservative management versus RFA versus SI joint and opioid utilization, I thought that was really interesting. I'd never seen that before. The one thing that kind of now as we look at, we have this option to do SI fusion in a pretty unique, minimally invasive manner with, a couple of the companies right now, more commonly for us. RFA seemed to be, a very low invasive thing, and we'd really kind of run to that first before sending them out for, a lateral fusion. I think most of us would probably do that, but now it seems like the conversation's shifting a bit. What do you think now as far as, RFA versus SI fusion, and now that, there may be some data out there that, potentially opioid use could increase if you chose the RFA route over fusion?
So that's an excellent question, Dawood. And I, when I look at this and I approach things with patients, I always think about what's minimally invasive versus more invasive, and then I think about outcomes. What's going to give my patient the best outcome long term? And so, yeah, it seems like an RFA would be minimally invasive, but is it really when you're going to repeat it once or twice a year for as long as the patient's remaining lifespan if they need that to happen? And then the other thing that, I've noted is that, these procedures, these posterior stabilization procedures take only 20 to 30 minutes. That's about the same time it takes me to do an RFA procedure. So even though I'm making a small incision to do the posterior stabilization, in reality, is it more invasive if I only have to do it once, and it gives me a superior outcome looking at some of these studies that we're looking at now. So in my practice, I'm starting to look to encourage patients to encourage that and highlight these two benefits, that they could get long-term sustained pain relief from a one-time procedure that only takes 20 to 30 minutes versus a procedure that has to be repeated over time. So I'm looking to move it up in my algorithm, or as a second option after they fail conservative care, which includes an SI joint injection.
Dennis, that's a really great perspective. We just published a paper, myself, Dr. John Hagedorn, Allison Engel, and Abhishek Yadav, that showed that the more opioids someone was on, the higher the chance they'd fail ablation. So I think, so your new algorithm makes a lot of sense. Stephen, I have two questions for you, but I think you can answer both very briefly and very accurately. Question one is, we have people who believe the lateral approach is better. Dr. Rashbaum, who's a colleague and friend of mine for many years, has reached out to me and said, he thought the lateral approach made more sense and was a better approach. So I'd like to ask you why we consider a posterior approach. What would be, I know you and Dennis both talked about it a little bit, but just summarize that for us in maybe a minute or two. And then secondly, we now have interspinal spacers, minimally invasive lumbar decompression. We have kyphoplasty, and myself and many of my colleagues do those procedures. What is the level of skill set it takes to do a posterior fusion? If you can do those procedures, can you do a posterior SI joint fusion?
Yeah, sure, absolutely. So I think one of the big things with the lateral approach is obviously that's what established the data in the space for SI fusion. So, and it was always based on the surgical approach, and it was the first approach. It's still actually the most common approach performed by surgeons. In fact, up to 70% of SI fusions are performed by the surgeons via a lateral approach. So one is, I think it's a historical perspective, that the surgeons learned it that way and stayed that way. They also have great data for it. So we are adapting a posterior approach, which as of right now, we don't have the same level of data to compete with that. But we are starting to develop that data, and we are starting to see the patient outcomes that are mirroring what we saw by the surgeons. And I think it's important to know that the field is just pushing towards more minimally invasive options for these patients, and not having morbid procedures that you would be non-weight bearing for several weeks, that you would be transgluteal with the risk of vascular or nerve injury. So I think that's where we are right now. I think the posterior approach allows it to be in an interventional pain physician's hands. I think to answer the second part of your question, I think the skill set for the interventional pain community is, I think those interventional pain physicians who feel comfortable doing pump therapy, who feel comfortable doing spinal cord stim therapy, who feel that they can appropriately place RF needles for the SI joint to actually do a true ablation to that joint. I think those are very good skill sets for saying that you'll actually do very well by doing SI joint fusion via a posterior approach with grafts.
So I just want to summarize what you said, and then give David the last question or comment here in the session. I think what you said was, and correct me if I'm wrong, is that the posterior approach is going back to what Dennis said and what Stephen said. It's less invasive than lateral approach. It's less risk. Probability of risk is much lower. For someone who does percutaneous procedures, it's an easier area to learn, and if successful, it certainly is a less invasive thing for the patient. So they're weight bearing, they're home that same day under local anesthesia with little sedation, all is an advantage. And certainly we're going to look at data for cost effectiveness. Does that summarize it pretty well, gentlemen?
I think so. Yes.
Yes.
Okay, Dawood, back to you.
Yeah, great job, gentlemen. Thank you for your time. It was outstanding and very informational for me. I think, Stephen, you're staying on the line for the next session as well. So our next session, we're going to jump into
Thank you, Dennis.
Thanks, guys.
New innovations in minimally invasive SI fusion. We'll have Dr. Josephson, Dr. Falowski, Dr. Tate. The session will be moderated by Kazar Amerdelfin, and then our well-respected neurosurgeon in our space, Dr. Jeffrey Henn. Cass?
Good evening, everyone. Thank you so much, Elwood. Thank you so much, Dr. Deere. It's my pleasure to launch the pain tech session for the SI joint fusion, talking about the link procedure, which is a posterior percutaneous approach to an SI joint fusion. My name is Cass Hammer-Delphin. I'm the Director of Medical Research at IPM Medical Group, which is a large multi-specialty group in the state of California. My practice is outside of San Francisco, and I've been doing this now for about 20 years. And I'm now starting to realize that I had been underdiagnosing SI joint pain for quite some time, mainly because of the fact that I really didn't have a lot of good treatments for it. We had done injections, we had done radiofrequencies, things like that, physical therapy, all with limited outcomes. Over the past couple of years, I've been using the percutaneous SI joint fusion process, and I've had some fantastic outcomes. So more and more, I'm finding SI joint dysfunction in my practice. So it's my job to get us started with this session. So I'm just going to go over a few things. I think Dennis Patterson did a fantastic job going through the prevalence of SI joint dysfunction in all of our patients and how they happen. But let's go move on to the next slide so we can look at the algorithm. Basically, there is about 20% of patients who suffer from low back pain move on to have chronic low back pain. And 30% of those patients end up having some type of sacroiliac joint dysfunction. We estimate that over 10 million people here in the United States are suffering from SI joint dysfunction. So in fact, this is a large patient population. I guarantee you that all of us have these patients in our chronic pain management clinics. And up to the recent past, they've been very difficult to treat. Now we have some solutions that we can look at. They're very misdiagnosed quite often. We think about spinal diseases, lumbar disc disease, lumbar radiculopathy. Sometimes they can actually masquerade as these kind of things when we see it. And the lateral approaches have been exclusive to the surgeons. And as interventional pain physicians, we've hesitated to send the patients out for a lot of the different issues that we've seen with lateral approaches that Dr. Falowski and Dr. Patterson just went through. Next slide. So basically, these patients show up to our offices, and as you look at them, as you get the history from them, they sometimes come in and they complain of some localized pain that they point to, and it's almost always around the sacroiliac joint line. It's usually below the L5 level. It could be lateral to the PSIS. Sometimes it goes down into the lateral hip and maybe all the way down to the calf as well. A lot of these patients have had fusions, which puts a lot more pressure on the synovial joint within the sacroiliac joint itself. And they may have structural abnormalities like scoliosis, which changes their gait and puts a lot more pressure on a unilateral sacroiliac joint. Pain hip pathology, such as severe arthritis or even hip replacements, can contribute to SI joint dysfunction and these patients having this pain. There's a big prevalence of SI joint dysfunction in postpartum females, mainly because of the fact that the pelvis has to relax to allow the mothers to be able to deliver the babies in a safe manner. And because of that, they develop a lot of sacroiliac joint dysfunction afterwards. So if you ever see a young female patient in your practice who has localized low back pain, it's very possible that sacroiliac joint dysfunction is part of the issue, and it should move up to differential diagnosis. And obviously, trauma can cause a lot of sacroiliac joint issues as well. Next slide. There's a lot of different provocative tests that we do in our offices. My favorites are Favers, Gainsland, and compression. It's really, really important for everyone who gets a history and suspects a sacroiliac joint dysfunction to do these examinations and at least have 3 out of the 5 that they've documented before they move on to a diagnostic/therapeutic type of injection. It's really important that 1 out of the 3 is either the thigh thrust or the compression test. I don't really like the thigh thrust test. I think it's a little bit inconclusive in my hands, and that's why I rely on the compression test along with Favers and Gainslands in almost all of my patients. Next slide. So, we get a history from the patients. We can see whether they've tried conservative management or not. But if we suspect a SI joint dysfunction, we typically take the patients in and do a sacroiliac joint injection with local anesthetics and steroids. This injection is incredibly simple to do under fluoroscopic guidance. We look for 50 to 80% pain relief in these patients. I know Dennis talked about much higher percentages, but if I'm over 50%, I'm typically happy with my outcomes. But I definitely check the patients in the PACU myself. After the local anesthetic and steroid injection, I give them just a few minutes to relax and unwind from the injection itself. Then I go into the PACU and I examine these patients and I try to see if I've gotten significant pain relief in them. And if I have, then clearly the SI joint is the originator of the pain, and we can move on to either additional injections and conservative therapy focused on SI joint, or move on to some other invasive procedure such as radiofrequency or SI joint fusion. If the pain relief is less than 50%, clearly the SI joint is not the only pain generator, and we need to look for other issues as well. Next slide. This is just a very complicated looking algorithm that shows that if you suspect SI joint dysfunction in the patients, get the history, do the physical exam, do the diagnostic/therapeutic injection. If the injection is successful, meaning the patients get greater than 50% pain relief, then we could potentially start with things like non-steroidal anti-inflammatory medications or physical therapy, or even try radiofrequency, although in my experience, radiofrequency doesn't work that well. And if the conservative measures fail, you can move on to a second injection. And after the second injection, if the pain relief is not long-term, the patients could potentially be considered for a sacroiliac joint fusion. Next slide. I'm fairly new at this. I've been doing this for about 2 years, but that's why we have Dr. Jeff Henn and Dr. Stephen Falowski, two of the foremost experts and key opinion leaders in sacroiliac joint fusions and dysfunctions here with us. I'd love to hear their perspective, and hopefully there'll be some time for me to ask a couple of questions from them as well. Dr. Henn, Dr. Falowski, the floor is yours.
Well, I'll start, and then Steve obviously has been doing a great job up to now and can jump in. I came to this from a complex spine surgeon's point of view, and this has really been an eye-opening experience and changed my own practice pattern, not only understanding what is often the pain generator in my patients who I just wasn't getting the results I thought I was, but also I've really dedicated my career towards moving from the big open surgeries to minimally invasive. And so while I was trained in the lateral approaches, I just couldn't quite bring myself to do the lateral SI fusion. I just didn't feel good about it, and just personal preference. And the posterior approaches have now opened up that door for me, and I kind of put it in that same venue as minimally invasive and all the benefits that come from that. So, Steve?
Yeah, I mean, perfectly said, Jeff. I think I came from a very similar background and being trained, a complex spine, being trained on the lateral approaches for SI joint fixation, and then now actually adjusting my practice to be mostly minimally invasive, and realizing that we don't necessarily need to do a lot of these big spine whacks to get the results that we'd like to have, and we can do it in a minimally invasive approach with whether it's interspinous devices, whether it's minimally invasive, even lumbar fusions, or SI joint fixation through a posterior approach, minimally invasive spinal cord stim. There's so many avenues we have now to treat these patients that we don't necessarily always need to revert back to the big, large open procedures, non-weight bearing, morbid type procedures. And I think that, obviously, Jeff and myself sort of bridge that gap between interventional pain and the complex spine world. But, it's our job to create education, not only for the patients, but for the interventional pain physicians, to know that these therapies exist out there, to build up the skill set, that interventional pain is more than just opioids and epidural steroid injections. But on the flip side, it's also the surgeons. I mean, the surgeons need to start realizing that not everything has to be fused in a big open surgery, and that they have to start embracing the relationships that they can have with interventional pain and create like a continuity of care with these patients.
Excellent. Jeff, I've got a question for you. Clearly you have a significant amount of experience with the lateral and posterior approach, and you're now choosing to do the posterior approach. As interventional pain physicians, we are really averse to using drills because it's just not in our tool set. It's not something we're used to. Can you comment on if you see any advantages or disadvantages of using a drill for doing these types of procedures?
Yeah, that's a great question. And I think in that question, there are a lot of different ways to think about that. So first, I think lateral versus posterior, it's really a fundamentally different strategy. Lateral, you're of course crossing the joint multiple times, relatively traumatic. That causes bleeding, that causes pain. That obviously is part of the reason they have to be non-weight bearing for a period of time. Whereas the elegance of the posterior approach is you're really saying we're going to work within the normal structural anatomy, the ligamentous anatomy, the cortical anatomy, and we're just going to take advantage of that. And that's the elegance of that. If you can say, well, what if we just come right down the axis of the SI joint and put a distraction force in there and ultimately get a solid fusion, then you've got really the perfect surgery in that case. It's minimally disruptive, minimal risk. And from the patient's point of view, I think it's kind of like if you showed a third grader both options, I think they'd all say, yeah, I'd want that one over there. It just kind of, it passes the sniff test. I think in terms of the drill, that is an interesting question. So we use drills all the time in spine surgery. Interestingly, one time we don't use a drill is when we're doing interbody fusions. And the reason we don't use a drill in the interbody space is so we've cleaned out the disc and we're now going to put a distraction force in there. As Steve said earlier, the body fuses much better under tension. So anytime you can maintain that. And so the concern is if you're trying to get a solid fusion and maintain that distraction, you want to be very careful not to violate the cortex. Obviously, as we all know, the cortical bone is incredibly strong, but within a millimeter or two past that, you get into that soft cancellous bone. So when we do a interbody fusion, after we clean out the disc, we use rasps and essentially scrapers, but I've never put a drill into a disc space for fear that I would actually damage the end plate above or below. And concern would be a couple of things. One, it would lead to subsidence. So you put your nice graft in there, you get a nice distraction force, but if you've literally, for lack of a better word, fractured the bone, you're now asking this broken bone to hold onto your graft. So bottom line, I like the elegance of the link system. I like the fact that it really models to me the same exact concept of an inner body fusion dropping into the space. And no question, I will say up front that interventional pain physicians are much better at that than I am. I don't have that skill set, or it came to me kind of late. But being able to cannulate that SI joint, once you've done that, you're 90% of the way there. Then it's just a sequence of distractor, rasp, and put in the graft, and you're heading out the door. So yeah, bottom line, I think that's where Pain Tech for me checks all the boxes. I like that system, and at least in my hands, I've had great results so far.
That's excellent. Thank you, Jeff. And Stephen, we've talked about how the complication rate with the lateral approach is significant. Now that you have a lot of experience with the posterior approach, what is your complication rate with that? Is it a lot less? Is it nil? Can you comment on that at all?
Yeah, absolutely. I mean, I think your complication rate with the posterior approach should be extremely, extremely low. I mean, complications you're looking at now could be infection, which obviously with proper precautions, your infection rate should be low. If you're actually going directly into the joint, as obviously is the plan with this, you're not going to be going through muscle or vascular structure. So your risk of any type of bleeding or hematoma should also be extremely low. The one major risk factor you're looking for or want to watch out for when you're placing grafts posteriorly is how far anteriorly you push them. Because the real risk is if you go too far anterior, you're now in the pelvis, as you can imagine, all those vascular structures and neural structures and internal organ structures. So that's actually the one part you have to be careful for. But I also think, in all honesty, interventional pain physicians are probably the most adept at using fluoroscopic imaging and realizing where they are in space. Surgeons have a very good idea of three-dimensional anatomy. That's why we place pedicle screws. We try to create a three-dimensional image in our head of the spine. but we're not very good at, necessarily using fluoroscopic imaging at much different angles and obliques and sacral inlets and outlet views to know where we are in space that way. So I think as long as you're very safe about not going too far anteriorly, your risk profile with this procedure is very close to zero as you can get with a minimally invasive procedure.
Excellent. And I can't wait to hear from the rest of the experts on this panel about their experience with this. But before we move on, Dr. Pawlowski, Dr. Syed, and myself, and a few other investigators are involved in a biomechanical study, and we have one slide on that. Dr. Pawlowski, can you just walk us through that slide?
Yeah, absolutely. I'm actually extremely happy to present this slide. And as you know, I just presented some of the biomechanical data we had with CornerLoc. And I think that being able to show this data across the different companies, different implants that are going in grafts, I think is extremely important. Next slide, please. And I think what we're starting to see, though, is that things can work by different mechanism of action. Things can work by decorticating different, whether it's through rasping and creating pressure or compression. So we don't have the slide up here yet, but I can still talk through it. So we're also doing a biomechanical study with Pain Tech, in which the graft is then implanted. We have so far a sample size of one joint that is compared to an intact joint. So we had biomechanical data from that intact joint and then put the graft directly into that same joint and then compared the two. And what we actually saw was that with that prepared joint and the graft in it, that when it came to flexion and extension, so bending forward and bending back, we significantly decreased the motion that was in the joint. So that answers that question of immediate fixation. We also looked at the idea of rotation. So it's the idea of taking your eyes and looking left, looking right, so you're turning your body. And what we actually showed also with that is we decreased the rotation, turning left and right significantly compared to the intact joint. Now what's interesting though, thank you very much. What's interesting now though is when we also looked at lateral rotation. So this is the idea of bending your body side to side. There was not a difference in motion, which is actually quite interesting because there has to be a certain amount of lateral motion within the SI joint. It's where your pelvis meets your spine. So you need to have that lateral motion. So it's interesting to show that it doesn't make abnormal biomechanics or abnormal decrease in motion for that type of direction. But what was also interesting though is when we looked at that lateral motion, we moved where the center point of the rotation was. So normally in the intact joint, the center of rotation is actually at the superior lateral portion of the joint. That's what it is in a normal, healthy person. But what's interesting though is that center of rotation moved to where the graft was. So what that actually tells you is that that's where the compressive forces are, or that's where the graft is working. So what that tells you is it's actually priming the joint as well for a fusion right around the graft. So this is obviously very early data. We didn't go through cycling with it per se, but what we were able to show was that you do get an immediate fixation, and you are starting to show the features that the compression forces surrounding the graft, which will lead to a fusion, as we talked about.
That's excellent. Thank you so much, Dr. Pawlowski. There's no question that we need a lot more evidence because nowadays interventional pain medicine fortunately has become an evidence-based specialty. And with that, I want to thank both of you for joining us. I'm sure there may be some questions for you at the end, but I'd like to turn the podium over to Dr. Syed and Dr. Tate, who will share some of the early evidence with the link system with us. Thank you guys so much.
Okay, thank you.
Great job. Thanks, Kaz. Can we advance to the next slide, please? And next slide. So I think, as with all therapies, as we try to embrace, it's very difficult to have a multicentered RCT on day one. So I think what I'm going to present over the next few slides is a start. It's definitely not where we want to end up, but it is a start, because the reality is that we're all starting to embrace this technology right now, day one, and we're basing a lot of our anecdotal data on a predicate device. So what I'm going to present over the next few slides is some of the specific outcomes, real world data that we have with the Link system. What we've presented evidence to date is a 20 patient case series that was presented in 2019 by Dr. Piles and his team. Also a minimally invasive intervention to treat failed post-lumbar fusion pain by Dr. Balter and Cook in 2019. I was proud to present initial experience with MIS fusion device, a retrospective case series at ASRA last year, as well as a Link SI fusion for pain relief in SCS patients. And then we'll also share our multi-center outcomes and another multi-center retrospective analysis. Next slide, please. So this is our initial experience at the University of Kansas. This was a 16 patient retrospective analysis. What we showed in this are twofold. Obviously, the follow-up time is still a relatively short window, around about 6 months, but we showed a very dramatic reduction in pain. So patients had pain levels of about 7 that decreased to 1 after their SI fusion. Also, these were patients out of a pain clinic. So a lot of these patients had SCS. Again, we'll share a little bit on that. So out of 11 out of the 16 patients actually had SCS implanted. So we showed that this can be a very nice adjuvant therapy to our patients that are quote unquote failing neuromodulation. And I think the biggest thing that we can at least derive out of this is that in the short term, there were no adverse events observed. So again, our neurosurgical colleagues, made a lot of time and effort to describe how the posterior approach seems to be a very safe and effective way. So in this, we also showed that we proved that there were no adverse events. Next slide. This is our multi-center outcomes study that was led by Dr. Chris Lamb, one of my former fellows and now my colleague at the University of Kansas. This was also combined data with Dr. Balter in Nebraska and Dr. Piles in Florida. So again, this was a 75 patient multi-center 3-month outcome study. The average VAS reduction in this retrospective study was around 7.89. In patients in which opioid usage was recorded, we showed an average reduction of about 36%. Again, hitting on no adverse effects. No adverse effects were noted in this patient population, and this was accepted for presentation at ASAP, and the manuscript is now in submission. Next slide. I touched briefly on SCS patient population. So this was a case series that we presented at NANS last year. Again, looking at patients with failing or uncontrolled pain that had implanted SCS devices and using the Link procedure as a way to put these patients back into responder or decrease their pain level. So again, you can see pretty high levels of pain prior to the intervention. So the SCS not providing adequate pain relief with VAS scores of around 8. After the fusion, VAS scores dramatically reduced to around 1.5 to 2. So again, I think this is something, especially in our SCS patients that are status post-lumbar fusion, it's something that we all need to be thinking about. In our institution, what we will do is we'll have them turn off their SCS device for a period to allow adequate washout, which can be 12 to 24 hours. And then we'll bring the patients in for a diagnostic SI joint injection. If their typical pain that they're struggling with over the recent history is reduced, then our eyes kind of light up for us. This is likely uncontrolled mechanical pain from sacroiliac joint dysfunction and not really a failure of the SCS. So again, I think this is something we all need to be aware of. Next slide. So future directions, again, Dr. Falowski gave a little tease of the biomechanics study, which is going to be the first human model study for posterior SI fusion. He's doing a great job leading that. Dr. Tate is going to take it on to, again, this is not enough. So there's a multi-center study prospective that Dr. Tate is going to share with us. Jordan?
Thanks, Dawood. Next slide, please. And thank you to ASPN so far for putting on such a comprehensive and thorough overview of posterior sacroiliac joint fusion. The SECURE study, which is a single-arm, multi-center prospective 12-month study is currently enrolling and is expected to have 150 patients. It's going to be involving some of the top scientific investigators across the US. If we could move to the next slide, we can see their names. And the next slide, please. The anticipation is to have a 12-month follow-up. So this is going to be one of the largest studies with the longest follow-up to date. The outcomes to be evaluated include VAS, ODI, patient satisfaction, of course, opioid reduction, and this will also be a safety evaluation with adverse event reporting. The purpose is to investigate and evaluate the safety and efficacy utilizing LINQ or PainTech for sacroiliac joint disease. The anticipated end enrollment will be in October, and we look forward to seeing the results from the SECURE study. One of the great things about PainTech is their commitment to increasing the data and evidence in our space. Next slide. So I'm going to bring Dr. Josephson on for the next section. We're going to discuss why we have chosen to incorporate PainTech and LINQ into our practices. Hey, Joe.
Hey, Jordan, how are you?
Wonderful.
So, good. Thank you for that introduction and great job discussing what's going to be a really important study that we're both lucky to be part of, and it's going to show some great data, I'm sure. So I was asked to talk about why the LINQ system, and you know, it's funny because we have a bunch of slides that we put together that, you know, kind of go through this, but, you know, I think kind of going away from the slides is really, there's so much change in our space right now. I think this is one of the really great times to be a pain management physician. You know, when I think about our forefathers, what they had was epidurals, and they had treatments and they did the best they could for their patients, but did they structurally change, you know, dysfunction in their patients to get them to better places with minimally invasive techniques? A lot of times they didn't. And then with kyphoplasty and other advances that came forward, and interspinous phases, and now, you know, treatments for the SI joint, we are really now in a super exciting time to be a pain management doctor. So, you know, a little bit of background about myself. As a physiatrist and a DO, I've always been a huge advocate for SI joint pain. I see it as a really, really common pain generator in a lot of our patients. And for a long time, all we had was, you know, SI joint injections, which we did, and, you know, they helped patients for a period of time, and then RF came about. And then once posterior approaches came, this was really an opportunity for us to really, you know, do more, and I jumped right in. So when you're looking at any new intervention, you know, the reasons you use one company over another, especially in what is now a more crowded space, it really boils down to three simple facts in my mind. And these determinants are the simplicity, the safety, and the reliability of the procedure. Because let's face it, you want that procedure to be reliable. You want those outcomes to be good. And you want that patient to get a benefit no matter what. The reality is that the reliability of this procedure is very straightforward because it is a very simple procedure. I think Dr. Hen said it before, and the word that I like to use is it's an eloquent procedure. It is a very easy to perform, very simple procedure using one incision approach, and that single incision allows you to deliver what is a really smart device. So the procedure uses known principles in spine surgery. By using a larger implant that is filled with DBM, you're able to get into the joint and stabilize that joint in a very easy and simple way. And to be honest with you, that fixation occurs almost immediately. So you place a device and you get that mechanical fixation that occurs. And I've had patients, you know, jump off the table and, you know, tell me how good they're feeling almost immediately after getting the procedure done. So, you know, with that, and then, you know, that is just simply the wedging of the device into the space. As the fusion occurs over time, you get, the patients just seem to get better and better as time goes on. So for me, it was really kind of a really simple approach. And the reason I used it seemed almost like a no-brainer for me. So I guess I'll shoot the question back at you, Jordan. What's your reason for using PainTech?
100%, I agree. I'm also a physiatrist, and I can recount so many patient stories where I have received patients either from surgeons or even other pain physicians who have been sent to me for medication management or SCS, and I review their records and I review their, history and physical, and immediately I see that the SI joint has been underdiagnosed and underappreciated. And we hone in on that diagnosis and then treat them adequately. So understanding that sacroiliitis or sacroiliac joint dysfunction is completely underappreciated is number one. Once I decided to incorporate SI joint fusion into my practice, I realized that there were many options. And really, the space is becoming very crowded. And in fact, the first system that I trained on was a system that incorporated a drill. And being a non-surgeon, physiatrist, interventional pain physician, getting that power tool in my hand the first time was a little exhilarating, but also I realized very quickly that it might be something I want to leave to my surgeon colleagues. And also the expense of purchasing a drill for an ambulatory surgical center as a private practice physician was not something that we were willing to take on. So then looking at the other options that were non-drill options and looking for a simpler design and an easier procedure, Pain Tech became the obvious choice. Really what stood out to me was their commitment to research and their commitment to promoting data and evidence in our space. I think that's really honorable and worth committing my patients and my practice to.
Excellent.
So great session. Really, I think very insightful in every way. So Jordan, Joe, thank you so much. I think that was a great way to finish tonight. Jordan, you have any closing thoughts before we close the session?
I just think that was a really very thorough and comprehensive overview, and I thank you guys for allowing me to be part of the ASPN presentation tonight. Thanks so much.
ASPN's really fortunate to have you and Joe and Stephen and the whole group tonight. So thank you all so much. Dawood, here we are, end of night 3. So I want to thank everyone for joining us. I'll give you the closing thoughts and I'll see everyone next week. Everybody have a great weekend. Dawood?
Yeah, thanks everybody again for tuning in. I think it was nice to kind of pivot a bit and step away from spinal cord stimulation and talk about intrathecal therapy and minimally invasive spine. We have a couple more really interesting sessions coming up. Our annual meeting obviously is coming up in September. More to follow on that. I think it's going to be really the marquee virtual event of the year. So we look forward to hosting you guys all on that. Next slide.
And we will be live together in Nashville, Tennessee, in a very special studio with a special way to present that meeting. And it'll be CME accredited, as many of you know. So it's a good chance to get your CME since you can't travel to get those right now for your licensing.
Yeah, Tim promises not to make us all listen to country music the whole time.
We'll listen to country music the whole time. It's going to be a country music-based meeting.
Session 4, peripheral nerve stimulation. That's going to be coming up on Monday, August 17th. This is really going to be, I think, a really fantastic lineup. We'll also be talking about RF ablation. So we'll take some of the thought to the periphery on Monday. Next slide, please. Session 5 will be minimally invasive spine. So again, we'll be talking about things like the Vertiflex procedure, minimally invasive lumbar decompression, and then we'll also have our closing think tank session with spinal simplicity and Biotross. Thank you everyone for tuning in tonight. We look forward to seeing you guys on Monday.
Good night, everybody.
Good night.